Good morning and welcome everyone to the Endeavor Health Outcomes Research Seminar and the ninth in our Health Equity and Implementation Science Research Series. Today we are fortunate to have Professor Sam Volchenboum from the University of Chicago, who will be presenting his work on the Institute for Translational Medicine Sociome Data Commons, Part 1, an overview of the program. We will also be joined by an expert panel, including Dr. Emily Dillon, Dr. Charlie Neuwenhuis, and Dr. Anthony Solomonides. My name is Sean David. I am a program director for Translational Science Outcomes Research at Endeavor Health and vice chair for research in family medicine. And I'd like to introduce Rachel Brewington, the facilitator, who is our administrative assistant lead and my partner in this seminar series. And thank you, Rachel, for all the great work that you've done. I'd like to start off and just say a thank you to all the first responders, people working in the community with lived experience at every level on the front lines of the quest for improved health equity. Just to go over a little bit the seminar and our objectives. Our objective for this series, which is a CME event, is to advance the implementation of health equity in our health systems, health equity in our community, policy change to promote equitable care and outcomes, and for advancing translational science. We really want to support clinical investigators from diverse backgrounds and disciplines, foster collaboration, team science, connect researchers across Chicagoland, and also provide outcomes research that shows improved patient and outcomes and equitable community health. Next slide. So the learning objectives of today's seminar are first to understand the goals of the ITM's informatics core. Secondly, to understand what is the sociome and why it is important to study. And thirdly, to appreciate how the sociome data commons will enable research. Next slide. As part of the Institute for Translational Medicine and our CTSA, we are focused on translational science principles, and each of these seminars addresses one or more of these areas: creativity, innovation, focusing on unmet needs and generalizable solutions, cross-disciplinary team science, efficiency and speed, and we tend to present really bold, rigorous approaches that advance diversity, equity, inclusion, and accessibility, as well as boundary crossing partnerships across institutions and regions. Next slide, please. I'm going to hand this over to Rachel, who's going to talk about obtaining CME credit.
Thank you very much, Dr. David. Hello, everyone. To mark your attendance today and claim CME for this session, text the SMS code to the number listed on the screen. For this live activity, the University of Chicago Pritzker School of Medicine offers a maximum of 1.5 AMA PRA Category 1 credits. Physicians should claim only the credits that match their participation level. Other healthcare professionals will receive a certificate of participation. If you're interested in how these certificates apply for AMA PRA Category 1 credit from ACCME accredited organizations, please check with your professional licensing board. The CME flyer will be sent to everyone via email today on more how you can receive that CME credit. During today's webinar, you'll be muted, but feel free to ask questions or share comments using the chat function at any time. Just remember to consider your audience when posting, and if you have something to contribute to the discussion, make sure to address it to both the panelists and attendees so everyone can participate. Thank you.
Thank you very much. So I'd like to go over an agenda for today. After introductions, we will welcome Dr. Volchenboum's lecture, which will run until about 11:45. During that time, we encourage you to put any questions that you have into the comments. Rachel will then read those to Dr. Volchenboum during the Q&A. And then we will have our Incubator Hub expert panel discussion with our 3 visiting panelists and Dr. Volchenboum. And we can follow up with some closing remarks where we can also provide information about evaluations and where to find this seminar videoed on our YouTube channel. So without any further ado, I'd like to welcome Professor Sam Volchenboum. He is a professor of pediatrics, a physician scientist who specializes in pediatric cancers. He's also associate director of the ITM and associate chief of research informatics officer. And he's also associate dean for master's education at the University of Chicago. So Dr. Volchenboum, welcome, and thank you so much indeed for presenting with us today.
Great, and thank you for the opportunity to come speak here today. Very excited to speak about our ITM informatics initiatives, especially our Sociome data commons. The work you hear today is representative of the work of the ITM informatics group that is led by myself and Susie Burrs, and a big shout out to thank you to Susie for help in preparing this presentation and much of the material that you're going to see here today. So I'm going to give a little bit of an orientation and background to the ITM informatics group. I'll talk about our three-part vision for how we're thinking about informatics within our Institute for Translational Medicine. Spend a little bit of time going over how we think about researcher user journeys as well as community user journeys that are enabled by the ecosystems that we're developing. We'll spend the bulk of the time talking about the Sociome data commons and the kind of research it's enabling, and then we'll have plenty of time for discussion. Should note that at the bottom of the page are a couple important links. The first is the link to these slides, and you can download them at any time, either now or after the talk. And there's a link there to our Data for the Common Good website, which is my research lab, as well as a link to the ITM website as well. This is the program leadership for ITM informatics. So the Susie Burrs and myself co-direct informatics for the ITM. Brian Ferner's a longtime collaborator and the director of the infrastructure for the Sociome. He is also the director of infrastructure and data for my research lab. Liz Zampino, many of you have met now, is our program director for the Sociome Data Commons. And for the time being, Kat Bouzine has been filling in as our program director for our Collaborator Finder project. And we expect this team to continue to grow, especially as the use of the Sociome Data Commons continues to expand. I'm sure you'll see some familiar faces here. These are the ITM informatics leads from our ITM institutions. Julie Johnson at the University of Chicago, who is the director of the Center for Research Informatics, is the informatics lead here. Tony Salamonides, who is on this call, is our lead at Endeavor, formerly North Shore. Michael Baltazzi, who used to be at University of Chicago with me, working in the Center for Research Informatics, is now our lead at Advocate Aurora. Carlos Santos is our longtime lead at Rush, and both Ron Price and Cathy Bobe share leadership responsibilities at Loyola. And I'm sure many of you have worked with these individuals. These are longtime, dedicated collaborators who have really tried hard to upend some of the institutional barriers that we've seen over the past years in trying to make sure that we can share data in a way that is, I think, innovative and is advancing science. We have our ITM Central Executive Committee at the top, which is made up of our ITM principal investigators. And then we now have created this committee structure, which includes a data sharing committee, our LEAF development group, as well as our informatics cluster on the right, which Susie and I lead, and then is made up of our informatics leads. So we have a fairly comprehensive governance structure that governs a lot of the work that you're going to see here today. And as you, so those of you who have worked with our group over the years know that governance is a central keystone to the work that we do because it really powers then all the downstream work. So when we think about the Sociome, I think it's tempting to just think about our social and environmental determinants of health. but it really goes beyond that. And we think about the sociome, not just, for instance, thinking about somebody's level of physical activity, but where does that physical activity take place? Are they a marathon runner and that's their physical activity, or do they have a lot of physical activity because they have a job that requires intense physical labor? If somebody lives in the very far south side of the city, are they exposed to different pollution than if they live on the north side? And how does that affect their lived environment and their exposures and their how they respond to different diseases? So I think when we think about the sociome, it's a much more expanded definition. And as we've thought about this, we want to acknowledge that there are many different social, environmental, behavioral, psychological aspects of lived lives that influence health. But we also want to emphasize that we're talking about large data sets here, and we want to be able to use these data sets to compute and think about how these factors work together to help influence somebody's response to disease. Many of you have seen this picture. It's from a Bay Area report from San Francisco from probably about 10 or 15 years ago now. And I think it's really illustrative in that if we look down on the right, which is the distal area, this is where we as caretakers and clinicians spend much of our training. We think about how to prevent disease and injury. How do we prevent chronic disease, say through smoking cessation? How do we affect behaviors? How do we use vaccinations to help prevent disease? How do we treat illness? This is really where we spend a lot of healthcare dollars and where we spend a lot of effort. But this is a cascade. And if we think about looking upstream, there are a lot of factors which can affect someone's health that are really more insidious. So think about somebody's ability to get good housing, or somebody's how much mold they have in their house, how good somebody's public transportation is, how good the schools are, whether they live in a food desert. These are all really important factors, and they're proximal to these other issues that I discussed. And as we think about the sociome and the research that we're doing, we really want to try to move upstream to tackle some of these root causes. And when we think about the term structural racism, we're thinking about a lot of the factors in place that lead to these downstream inequities. So if you look at number 3, I used one of the many available large language model image generators, and I fed into it the following prompt. The sociome are the environmental, behavior, and psychological aspects of lived lives that can influence health. Draw a picture depicting the sociome, especially its big data computable nature. And I got a couple pictures back. Ideogram is wonderful. I think I may end up signing up for the subscription, but this is the picture of sociome that it gave me. I think it's actually a pretty good depiction. I mean, I cherry picked a picture that I liked out of several options. The others weren't as good, but I think it does show this complex interaction of factors that influence a person's life, everything from their lived environment to their own health to their cell phone. And as we think about the sociome, I don't think we should leave anything off the table. How far somebody lives from a Walgreens could be just as important as their access to public transportation, as important as the pollution that they have around their house. So let's keep a wide open mind as we think about what the sociome is. So it's critical, I hope you would agree, to account for sociome factors when performing research, because we know these sociome factors will interact with human biology to exacerbate and sometimes even cause primary disease and injury. And these sociome factors will disrupt social, environmental, and psychological securities required for best health. And as I said, these adverse sociome factors are often manifestations of structural racism or things built into the community that have been instantiated over the years that lead to these downstream problems. So as we've thought about ITM informatics and our 3-part vision, we think about enabling research using these 3 tools. The first is our cohort discovery tool, which is LEAF. LEAF is an open source cohort discovery tool, which was developed as part of the CD2H project at University of Washington. And Nick Dobbins, who's now at Hopkins, developed this. Actually, Liz Zampino, who now runs our Sociome Data Commons project, actually worked on the LEAF project with Nick at University of Washington. And this cohort discovery tool allows us to do cohort discovery over the patients in our electronic health record systems. But more importantly, the Leaf discovery tool allows us to do federated search so that we can now search over multiple health systems at once. And we've now successfully connected the University of Chicago, Rush, and Loyola together so you could do a distributed search. And we hope to bring our other partners online soon. I'm not going to talk much about the ITM Collaborator Finder, but we have, as part of our aims of our current ITM grant, to build a Collaborator Finder, which goes way beyond the type of profiles identification that we normally would think of when we look for collaborators. So this isn't just a way to find other researchers who have the same PubMed mesh headings as you. This is going to be a way to use sophisticated new AI-driven tools to find the best collaborators for your project. We are in the early stages of working on Collaborator Finder. We've only been working on it for the last year or so. And so as we develop this, we would love to find other partners and other folks to work with. And then finally, of course, the Sociome Data Commons, which we'll spend a lot of time talking about today, is the centerpiece of the vision that we have for ITM informatics. As we thought about this, I thought about the following types of journeys. So a researcher might have an idea to do a project. And the first thing that researcher may want to do is identify other collaborators. Now, these could be collaborators at other institutions who work on the same area, or it could be collaborators that they need because they're missing that particular talent. Say it's somebody who needs to find somebody else working in machine learning, for instance, and they don't have that particular kind of expertise on their team. Then they have to identify the patients they're going to study. How do you identify the cohort of patients, both within your institution and perhaps within a larger set of patients? This curation of data is extremely time-consuming, expensive, and requires pretty intense data science experience, and most research labs don't have that at their fingertips. So providing this data curation as part of the tooling, I think, is incredibly important for researchers. Making it easy for researchers to do the right thing when it comes to data sharing, understanding the data sharing agreements, understanding how to write an IRB, understanding how the data can be used for downstream applications is something that we should enable for researchers. And then I think we should provide platforms to help enable analysis and help enable the publication of papers, because not every lab is going to have the full complement of expertise needed to collect and use and analyze and publish the data. So I just want to go through two potential user journeys that are enabled by these different ecosystems. So let's imagine there's a researcher who's looking for both data and collaborators. So I'll use my collaborator, Radhika Pedinti, who's a hematologist here at University of Chicago. And she may have a question: does pollution and noise affect sickle cell pain crises in children? It's a good question. Very difficult to get at if you don't have access to the right tools and data, but an important question to be able to ask. So the first thing Radhika might want to do is try to figure out, are there patients that she can study? So she could use the Leaf cohort discovery tool, and she could search within University of Chicago, and these numbers are made up, but these are not actual numbers. But she could search for sickle cell patients who are under 21 at University of Chicago. And then she could use a distributed search across our other ITM institutions, right now just for Rush and Loyola, looking for other patients with sickle cell disease, developing a comprehensive cohort of patients across the city. The next thing she would want to do is find collaborators and people to work with. This could include both community partners as well as collaborators across the ITM. And of course, right now it's a who you know kind of game. We tend to know the people we work with, and it's not hard to Google different people working on sickle cell disease at these institutions. But how do you actually get at people that are doing research, that have a track record of publication, that are people that would be open to collaboration? That's what we want to try to develop with the Collaborator Finder tool, which is to help you find the right types of collaborators. I just had an experience the other day where one of the fellows, our clinical informatics fellows, asked me about a particular type of, he wanted to do some research using, looking at people's eyes as they use an electronic health record. I have no idea who's doing that research. I didn't have a collaborator finder to use, so I used the next best thing is I emailed Julian Solway, who's like my collaborator finder. And of course, Julian, within a day or two, had a list of names for me to contact. That is not sustainable or scalable. So the collaborator finder is really, really important, and we have a lot of high hopes that it's going to be a really valuable tool. So once Radhika identifies her collaborators and finds the different types of data she can use, then we want to make it easy for her to put the governance guardrails in place, help with protocol writing, help getting an IRB approved, not only at U Chicago, but across the institutions for data sharing, and put the right contracting in place so that all the collaborators have access to the data. The Sociome Data Commons should make it easy to geocode the clinical data, making sure that for every patient, we understand what their physical location is and that we could line that physical location up against the other Sociome Data Commons data sets, which I'll review. Once the study is done, we want to make sure that the modeling and analysis can be done, and then the study can be published. So you can see this entire pipeline here, which is absolutely critical, is really going to be enabled by the different ITM informatics tools we have. Right now, this is a stochastic process. Most people just figure this out as they go along. A lot of people give up early on in the process, or they'll just do a single institution small study, or they won't have the right tools at their fingertips. So we think that at its least, the ITM tools can help enable a whole new kind of research that can really help translational research across the ITM. We don't want to forget about community researchers that are also looking for data and collaborators. We tend to think of most of our researchers at our academic institutions, but consider a community researcher that might want to study food insecurity and think about how not having access to high quality food or not having access to enough food could affect sickle cell pain crises in children. Here, it's even more important for somebody to be able to find collaborators. Because in general, our folks in the community may not know the extent of the collaborators across our ITM the way we do. And so having the collaborator finder available so that a community-based researcher can find collaborators across the ITM is absolutely critical. Then we can do the cohort discovery, and then we can do the rest of the work to write the paper. I think this is an incredibly important use case, and one I think that we have not paid enough attention to over the years. And imagine the power of opening up this type of research across the community. I'm very excited to see how these ITM tools will enable this type of research. So we'll continue to think about other user journeys, and we would love your help in thinking about this too. So we talked about the University of Chicago researcher that has a research idea. We talked about the community researcher. We could think about different ITM navigators, support for our trial innovation network, different ways to speed recruitment to studies. There are other user journeys that the ITM tools will build out, and we welcome feedback and ideas for other ways that we could enable research using these tools that we're developing. I'm going to spend a few minutes talking about the Sociome Data Commons, and the Sociome Data Commons continues to evolve. And what I hope you'll get by the end of this is an excitement to want to use the Sociome Data Commons and an understanding that it is ready for use in certain ways, and by using it, we can help improve it and speed its development. We're often asked how the Sociome Data Commons differs from other similar efforts across the country. And there are many different groups, some of them CTSA, some of them not, that are developing things that look and sound similar to the Sociome Data Commons. There are people collecting large amounts of environmental and other types of data. There are other people that are building indices into their electronic health records. And while some of these share similarities to what we're doing in the Sociome Data Commons, I think there's some fundamental differences. We want to try to build something that is agnostic to the analytic platform. We want to let people download the data and use the data in any way that is fitting for the research that they're doing. We want to keep the conceptual range broad, and as I said, we want to think about Sociome as this huge idea where nothing is off the table, and we shouldn't be, and I remember Julian talking about the things that we don't know, all the different data sets that may be helpful or that may be useful. We have a lot of really novel data sets that we've been collecting, and as I go through them, I'm sure you'll see some data sets that are interesting for the kind of work that you're doing. We maintain this wherever we can, the spatial relationships between the data sets to whatever resolution we can get with those particular data. We don't necessarily tie everything to health indices. So we think about things like social deprivation index and these common other health indices. And we don't, while those are important, we don't necessarily link our types of data to those health indices. We are using machine learning tools to handle high dimensionality data, and we have ongoing and important collaborations with the Data Science Institute and the Computer Science Department. And we're leveraging those collaborations to use cutting edge machine learning and other AI tools to handle high dimensional data. We continue to support multidisciplinary research, so we're not just looking at research within our normal biological sciences, but we want to try to make sure that our data and our platforms are available across a wide variety of different academic areas. We have focused on hyperlocal data where possible in the city of Chicago, but we are doing this with an eye toward national data, and we want whatever we're developing here to be something that can be democratized out to other cities and other parts of the country. So I think just trying to focus on Chicago data, while important for development, is not really the way that we want to head. And part of our write-up for the grant that we're currently under was to talk about how we could disseminate the Sociome Data Commons beyond just our CTSA, but to many other parts of the country. As I said, we have a system in place to make the raw data available back to the researcher so that the researcher can choose their own platforms for analytics. And then something that I think is often overlooked, which is making sure that we can continuously understand how the data sets are governed. What are the licenses for the data? How can they be used? Under what conditions? How can they be modified or accessed? A lot of these data sets are just posted on a website somewhere, and you have to dig to understand what the licensing agreements are. We spend time understanding the licensing and making sure that the researchers that use the data understand the licensing as well. So fundamentally, these are the types of questions we hope we could answer. For instance, if we think that that pollution affects asthma outbreaks, asthma exacerbation in kids, would walking on less polluted streets reduce asthma attacks? Would we be able to reduce blood pressure by reducing violence in neighborhoods? These are important questions. I'm sure some of you have seen the work by researchers that have looked at things like blood pressure and obesity as related to violence. These are questions which we hope the Sociome Data Commons will enable. And we hope that researchers will keep a broad mind when they think about the different types of questions that they can ask. The Sociome Data Commons is a tool to analyze these large, disparate data sets to learn not only what makes us sick, but also what keeps us healthy. The data sets, as I said, include hyper-local information. So that's either the exact address of the patient, but in other cases, we don't have that kind of hyper-local data. So we have to rely on neighborhoods or census tract. We want to be able to look at different efficacy of treatment by sociome factors. We want to think about novel risk factors, which could then lead to interesting and novel interventions for patients. And even digging down into the epigenome and looking at epigenetic changes and how different patients respond differently to different sociome factors and how their diseases may be affected differently. So we could even think about if you're going to put somebody on Ozempic, how might their response to Ozempic differ depending on where they live and what their sociome exposure is? These are important factors, and they may not just be related to the environment, but be related to their epigenome and their genome as well. Here are some examples on the right of the different data sets that we've pulled and that and just different ways of looking at them. You can see the eviction filing rate data on the top left. The top right is looking at lead levels pre-1960, nitrogen dioxide on the bottom right, which clearly outlines the expressway system in Chicago, as does the noise data, which you see on the lower left, also outlining our expressways in Chicago. So obviously these data look interesting. We continue to look at different ways to scale and look at the different data sets and then apply these to our patient data. As we build the Sociome Data Commons, we obviously have to have a pipeline for bringing data in. And on the left is an example of one pipeline. These numbers are old. They're from one of our initial pulls. So looking at an initial set of Sociome data sets, around 600 data sets, we excluded some because they were either too old or they did not have the right granularity that we wanted. We looked at the potential data sets and then had to dig in and do an assessment of the quality of the data, of the richness of the current, how current the data was, and then to come up with a set of data that we thought were ready for inclusion. And this pipeline continues to be modified and verified, and we'll continue to try to bring in other data sets into the Sociome Data Commons. On the right are some examples of some of the data sets that we've looked at, and I'll have other slides delineating the exact data sets. But looking at things like schools, transportation, housing, looking at the American Community Survey, which is part of the census, looking at environment and pollution and social data sets. And we get a lot of advice from our ITM Community Advisory and Review Council, our Patient Advisory Board, our Industry Advisory Board. And so we're doing this with in full view of the community and with full understanding that as we think about data sets to bring in and how we use these data sets, this has to be done with a very careful eye toward community engagement and community involvement, so that there's full visibility and transparency with how we're collecting data and how it's being used. We did a pilot with pediatric asthma over the last couple of years. We chose asthma because it is a community priority and that the incidence is very high in our population. We know that there are persistent disparities in the incidence of pediatric asthma in our Southside population, leading to disparities in morbidity and mortality. And if you look at the asthma prevalence rates by race and ethnicity on the right there, you'll see a persistent disparity between whites and blacks. And then you can see the age-adjusted ED rates for asthma, which are quite high on the south side of Chicago, much higher than surrounding areas. So the goal for the pilot that we started using just UChicago data was to show that we could build a predictive model with children with asthma from University of Chicago, generate hypotheses for future research, and identify opportunities for both immediate but also long-term interventions to improve asthma outcomes. This pilot was done with not just the ITM, but also with collaboration from folks at Argonne, folks, as I said, from the Data Science Institute, which is made up of members of the Computer Science Department, and as well as folks from my research group, Data for the Common Good. These are some of the demographics from the study that we did, and I think the main numbers here is to show that the vast majority of patients seen for asthma at University of Chicago are Black. Most of our patients are on public aid or Medicaid, and 97% of asthma visits we see at the University of Chicago are from Southside residents. Now, this is not surprising given where we are located, but if we're going to look at studying disparities in asthma outcomes, the University of Chicago population is obviously a rich population to study. We've had a couple publications now. This was our first one looking at the Sociome Data Commons. And from this paper, we had a few insights. I'm just going to highlight the ones in orange here. These seem to be important for predicting worse outcomes or exacerbations of childhood asthma. One was the average age of housing units. Another was violent crime rate per 1,000 people. And then I thought one that was interesting was the urban flood susceptibility index. So one could imagine that this could have something to do, say, with mold in houses. And so this merits, of course, additional study to see why these factors are important. This is looking at the number of unique patients by census tract. You can see that, again, most of our patients come from the South Side. But of course, to really get a good look at the city of Chicago, we need to expand to include all of our ITM institutions. So this graph on the right shows the different ITM institutions and affiliates. So if we could expand this research across the ITM, we would have a much, much higher catchment area, and the results then could be much more generalizable. I always like to think about this reality check. So we did our on the left our asthma pilot and our Sociome data commons pilot. On the right is where we want to go. We want to really have Sociome data commons as a service. We want to be able to enable the study of any disease. We want researchers to come in to bring in their data sets and study different types of disease. And we're really sort of in the middle here now, where we've done our asthma pilot. We have other disease areas that are emerging, and we're trying to democratize access to the Sociome data commons. And I'll talk a little bit about our early access program to hopefully get more of you involved. So our early access program is called the Interim Privileged User Program. And we wanted to think of a way to get data into the hands of researchers without just opening up the data to everyone, to do it in a controlled environment where we could understand how the data are being used so that we could learn from it. So I talked about our pediatric asthma pilot. We had 6 data sets included with machine learning, and we showed the spatial cluster for asthma exacerbations. But now we're expanding out, and we have many other data sets available. We're trying to get more and more research going using the data. And Brian and his team have built out an infrastructure using Globus, which is a platform developed by Ian Foster and his group, which allows the sharing at large scale of granular data. So what the interim privilege user program is supposed to do is it's supposed to help users get involved early, have an easy path toward understanding the user agreements and provide them access to data, and importantly, to get feedback as they use the data and conduct their research. So the purpose is to engage a limited number of researchers to have access to the Sociome data commons for their own research. And the commitment in return is that the users will participate in monthly progress meetings. They'll allow us to collect information on how they're using the Sociome data commons. And of course, we'll look to these users to freely share their thoughts on how to improve. And hopefully there'll be some iterative development of the Sociome data commons that way. So far, we require that the interim users be from any ITM institution, so that's many of you on this call, that they have some analytics experience, either personally or in their lab, or access to somebody that has tools for the analytics. They have a research question that'll leverage data that is currently in the Sociome data commons, that they have a research interest in social determinants of health or social and environmental determinants of health, and that they can use Globus, which is our federated transfer mechanism for moving data around. We want the users to design and document research studies that require Sociome data, secure IRB approval if they need it. We want the users to document how they use the SDC and to document their progress and results. Again, participate in monthly meetings, and then hopefully evaluate with some sort of satisfaction score how they found the use of the Sociome data commons and the ecosystem. There's a relatively straightforward data use agreement that'll be put in place, which basically defines the roles and responsibilities of both the ITM as well as the researcher. And then the process is that we work with the interim users to see if they have the right data sets, work with them to sign the data use agreement. The user can then obtain and access the data through the Globus platform, and there's a screenshot there on the right. It's very straightforward and easy to use once you have access. And then we ask users to have these monthly check-ins where they can provide feedback and go over the results with us and tell us how it's going and help provide us with areas where we can have improvement. I have a couple slides just showing the types of data that are in here, hopefully to get people excited. We have data from the American Community Survey, which is census data, looking at people's employment and health insurance and income. We have a number of health indices. We have that table includes things like community resilience, social deprivation index, a social vulnerability index. We have lots of raw data available, including all of our pollution data at 2.5 p.m., satellite air pollution data, we have very granular pollution data, some of which we're hopefully going to end up getting from Argonne as part of their pollution sensing program. We have a table with a lot of social indices, including population loss, smartphone use, access to groceries, air pollution, hazardous waste, power plant information, Superfund information. We have indices related to tobacco use, mental health, physical activity, and sleep, and many others that you see here, transportation, lead risk, life expectancy, school proficiency, and so forth. So I hope as you look over these data sets, you're both, number one, stimulated to think about the kinds of research that you could do using these data, but also be thinking about other types of data you don't see here. These were just the ones that were available, that we grabbed, that we went after. But there are many, many other types of data out there. And what we would love is for people to come to us with ideas for additional types of data to take in. Now, all of you, I'm sure, realize that there are data sets that can be purchased. There are expensive data sets that are highly curated. And thus far, we have not invested in purchasing curated or commercial data sets, but that's certainly something we could investigate in the future if there was a need to bring in a certain type of data set for a particular type of research. Every organization in the ITM has users of the Sociome Data Commons as part of the Interim Privileged User Program. So far, the users are clinicians, public health researchers, we have residents, fellows, and medical students. We have a lot of different levels of expertise, but there seems to be a lot of experience in using social determinants of health. We have varying levels of progress in research so far. We're hoping to see some publications come out of this work. And so far, the users have been happy to agree to meet with our team on a cadence. There is one ITM pilot award that I'm aware of between Endeavor and UChicago looking at interstitial lung disease, idiopathic pulmonary fibrosis, and looking at sociome factors as a cause of IPF. These are some of the individual areas of research that we're seeing in our interim privileged user program. So, for instance, do individuals experiencing housing instability have higher hospital readmission rates? What health and healthcare disparities do individuals facing housing instability experience in comparison to those who have stable housing? How does neighborhood level deprivation, which is something you can measure by an area deprivation index, affect things like colon cancer recurrence among our patients here at UChicago? How does internal biologic and external social and structural factors impact asthma and physical activity outcomes in Black women with asthma? So these are just some of the areas that are being studied by our interim privileged users. And we would hope to add you to this list and hope to get you involved. We want to try to improve all these different areas, the accessibility, how useful the data are, how easy it is to interoperate with the data, what people think about our levels of governance and our ability to show lineage and data provenance and audit, how scalable the architecture is and how easy the infrastructure and how easy it is to use Globus to move data around. We want to try to make sure there's a particular level of user support that can help engage researchers. We want to make sure that the right analytic tools are in place. We don't want to over-engineer the system and we don't want to reinvent tools that already exist, but we want to try to make sure that we're creating a set of tools that are applicable to the widest set of users. If you're interested in joining the Interim Privileged User Program, you always can contact me, but you're welcome to contact Susie Burrs or Liz Zampino, whose email will be on the last slide. We'd love to hear from you. And even if you don't want to be part of IPUP, but you want to be part of some of the other committees, we would really love for you to reach out and talk to us. Here's a couple other example studies that are ongoing, looking at disparities in outcomes in uterine cancer. I mentioned the IPF study. We have an ongoing study looking at air pollution and head and neck cancer. And then we have an ongoing study looking at disparities in levels of lower extremity amputation in our Southside population. I mentioned this spectrum before, and I just want to, again, drive home the point that we're solidly in this middle section now. And by the end of next year, or by the end of this year, I'm certainly hopeful we're moving over to the right where we have a Sociome Data Commons as a service where people can bring their data and bring their ideas, and we can enable their research. So again, this was our vision. Our collaborator finder, I said, is underway. We didn't talk about it today, but happy to talk about that during the Q&A if it's helpful. We'd love participation and help from folks working on this. We talked about the Leaf Cohort Discovery Tool, which is becoming more and more hopefully available to our different users across the ITM. and the Sociome Data Commons, which I think will enable this whole new type of translational research. As always, very thankful to our PIs of the ITM and the other groups you see here. You're very welcome to contact myself, Susie, or Liz if you have any questions. Susie is on the call today, and she and I are happy to answer questions about the Sociome Data Commons. And I believe we're also going to have a panel discussion, which includes users of the Sociome Data Commons, as well as folks that have far more experience than I do in thinking about these community level issues. So I'm going to stop there, stop sharing, and hand it back over to Sean.
Thank you very much, Sam. That was an amazing presentation and work that your team is doing. Rachel is going to take some questions for the Q&A.
And I would, Sean, if it's okay with you, I would just ask that my co-panelists be available if they would want to help answer questions too, since, as I said, I am myself not a community health researcher at heart. I'm just trying to enable that type of research. And so I'm happy to answer questions, but I also want to make sure we can get the full viewpoints of our panelists as well.
Absolutely. And I'll introduce our panelists shortly. Rachel, do you have any questions to start off with?
No, just the one question so far that you asked, which was, if you want to take your question, but there are no more questions at this time.
All right, then. Well, thank you very much. So my question, Sam, is it's really impressive work. Can you comment on how you might analyze potential causative relationships between the incidence exacerbation clusters and, for example, with asthma, and some of the Sociome variables that are clustering across the geocode?
Yeah, so I think some of this again is this gets down to how granular the data are, how believable you think the geocoded clusters are. And I think it's tempting to try to use these advanced machine learning techniques when actually just using traditional statistical analysis will help answer the questions. But people are always wondering about looking at disease clustering. Do we have increased levels of cancer here or there, or increased due to lead levels? And these are the kinds of questions we're trying to answer. And Sharmali may have other insights into how we do these types of disease clustering analyses. But my understanding is that it really relies on the believability of the granularity of the geocoded data and the location, the location and site specificity of the data that you have in the commons.
Thank you. Maybe I should introduce Dr. Sharmali Nienhuis.
Nienhuis, yeah.
Nienhuis, apologies, who is a professor of pediatrics at the University of Chicago. She's also a biomedical informaticist, physician scientist, who is part of the Sociome Data Commons team. And also Dr. Anthony Solomonides, who is a program director for biomedical informatics and outcomes research at Endeavor Health. And we will also be joined by Dr. Emily Dillon, who is an assistant professor of psychology at Carroll University, and someone who has also been active in this work. Dr. Dillon will be joining us a little bit later because of an overlapping event. So please, Dr. Nienhuis. Charlie.
Yeah, thank you for having me. Appreciate the invitation. So yeah, I mean, I can definitely talk a little bit about like my experience. I think I was brought on because my expertise in asthma and focus on social determinants of health, particularly in asthma. And a lot of my work has been focused mainly on the individual level. So kind of like patient reported, social determinants of health. But I think what the Sociome Data Commons has really added to my research portfolio is being able to look at things at multi-level, so more at a neighborhood level and broader, to then think about interventions that we would develop to then address whether those neighborhood factors and individuals, so typically like multi-level interventions. as Sam shared, I have really thought about, like, I have an ongoing research program where we're looking at the impacts of physical activity on asthma, particularly in Black women with asthma. And with that, we, have been definitely looking at individual moderators, such as, income, their own individual income. But again, really trying to enhance our understanding of how walking as an intervention can really potentially improve outcomes, wanting to really see how it may be moderated by, again, access to green spaces, access to Chicago park districts that have programs, access to CTA, or other, transit. So that's something we can even look at the distance of, like, how far is a CTA stop from where they live. So those are definitely things that, as you can imagine, if you're thinking about physical activity, there's multiple neighborhood components. And, again, thinking about safety, pollution, all of those things can be utilized and then put into an analysis. I personally don't do the analyses. I have much smarter people that will do the statistical analyses for me, but really thinking about what that conceptual framework is, or that conceptual model, to, again, not only include things at the individual level, but thinking both at the neighborhood or community level. And then you could even think too, I'm sure there's variables that, we could think about thinking about policies. I think in one of the analyses we've thought about, like, looking at the number of registered voters. So the number of community centers that would really think about, okay, what is the community engagement? So not only looking at neighborhood factors, but how engaged is the community as a whole? Or again, thinking about number of voters, registered voters, thinking about how, that community may work together to change policies. So those are some of the things that I have been able to really utilize the Sociome Data Commons, and it's evolving and continuing to grow. So,
and you mentioned patient-reported outcomes. Are those factors things that could be PROs or collected by patients that go out, come back to the asthma clinic in a month or something like that? Is there any ways to track that presently?
So not in the Sociome Data Commons. Yeah, I mean, we here at U Chicago, we do have things linked with the patients in our EMR. So it could be something, if you were wanting to maybe follow lung function tests that are obtained during regular clinic visits, or asthma control tests, or other quality of life measures might be obtained during regular clinical visits. Another way too, as I am doing, is I'm kind of tacking this on to an ongoing clinical trial. So obviously, as part of that, we're getting, we're collecting PROs at regular time points. But there's definitely something to, if you don't have a ongoing clinical trial, you could definitely look at, again, factors that are maybe obtained from clinical visits, or even other data from the EMR, which would be maybe exacerbations, as we looked at in the study that Sam showed. But there are definitely a lot of other variables that could be considered, that's available in the EMR.
Great, thank you so much.
Yeah, no
Well, I think we should probably segue to the expert panel discussion, and having welcomed the panelists. Thanks again, Sam, for a great lecture. Introducing Tony Solomonides and Dr. Niehuis. As we start off, after hearing about the Sociome Data Commons and its goals to, I think, migrate towards a more open platform for service, for use, what do you see as some of the, how we might implement this to advance health equity in our health systems? So to the group. Thoughts of that.
I could start, and then
Yeah.
maybe Tony, if you want to jump in too. So I think some of the things that I can think about as a clinician is being able, Sam showed from our asthma pilot, certain things that that really tracked with asthma exacerbations, particularly flooding or other factors. I think we also, maybe it wasn't in that paper, but we're also showing that like shade cover, that's another, factor. So I think as a clinician, it's something that I can definitely ask my patients, once we do these analyses to be, something I routinely ask in my, HPI is, have you had any recent flooding or, in the past year or two, just to kind of get a sense if they have had flooding and how has that been mitigated. And so I think there are definitely ways that, again, we can really use these results to then, again, talk to our patients and ask these questions, or again, implement these social determinants of health screening so we can better learn. Because again, when the patients come into our clinics, we are seeing them for 15 to 30 minutes, which is a very small snapshot of how they're really living their life. And so I think this is really it really is able to show us, again, some of those neighborhood factors. So I think as physicians, that's one way to do it. But then I think as a health system, making investments into, whether it be, patient education, so that people know that certain factors are associated, or even here at U Chicago, we have a link program which connects patients with community health workers that can then go into the patient's home, do environmental assessments, and also connect patients with resources. So I think those are things that can be done, like, again, not only at the physician level, but also at the health system level.
Mm-hmm. And as a pediatrician or an asthma expert, then telling a patient based on your data, your analyses, that this really does matter, these factors here, that standing water leads to mold, leads to worse outcomes, but cleaning it up leads to better outcomes, can go, I'm sure, be really influential with the parents and so forth. So
Yeah. And I think too, I know Sam mentioned this, but also the fact that, this is the data from the communities that our patients are living in. It's not just like, oh, somebody did a study in Seattle and found these. This is what's happening directly in your neighborhood. We're using data that's happening in your neighborhood. So it's really this like hyper local data that we're able to share with patients. So I think that's really helpful, because I'm sure even what's going on the south side of Chicago may be different what's happening on the west side, what's happening on the north side. So I think really being able to share that with our patients is really valuable.
But that's such a good point. I mean, because so often we want to tell our patients what the evidence is and give them evidence-based research, but it's such a ephemeral concept. And if you can really say, in your neighborhood, this is what we found. I mean, how powerful is that? So that's a really great point, Charmalee. I hadn't really thought about it that way.
The IPF study that we're about to conduct at Endeavor, it began as a study already done by one of our residents, Dr. Neha Kaushik, who has shown an interesting effect in the progression of IPF, idiopathic pulmonary fibrosis, depending on the distance that a person lives from a highway. And this was suggested in the literature that there was a particular cutoff point at which perhaps pollution diminishes or cuts off very sharply. But there's a clear result that living less than 200 meters from a highway is detrimental, both for progression and survival. Now we want to repeat this, obviously, with a larger population in the Chicago area. So we're going to work with a colleague at the University of Chicago, but also, there's an opportunity to look more broadly for other possible causes of deterioration. Brown sites, factories, standing water. And that's essentially the main study that we will be beginning in pretty much immediately.
And this distance from highways, I'm just looking at some of those maps. It looks like west of the interstate, there's much higher density of pollution and nitrogen dioxide and things like that. I guess.
Yeah, you mentioned a very interesting concept, the idea of causal inference. We are looking to do some work in that area. For example, the highway effect may be a proxy for social deprivation in general. There is some evidence of that, and we can use some pretty sophisticated methods to try and untangle those.
Yeah, because I'm thinking about health equity and for our patients who may be proximal to interstates, like what kinds of interventions environmentally could we recommend, or HEPA filters, or either nitrogen dioxide filters, or I don't really know.
Yeah.
But I think causality probably has some relevance to, what do we send patients home with, or what might community health workers be able to address. So it's an interesting conversation of how that might gets translated into mitigation.
Yeah, I mean, thinking in terms of equity, it's obviously a problem that you can't always do very much about what it is that you've discovered, that many of the patients who might benefit from moving away from a highway probably don't have that option.
Yeah, thank you. Dr. Dillon, thank you for joining us. And I know you've had a busy morning.
Yes, thank
you. And we listened to Sam's great talk about the Sociome Data Commons and the incredible platform that's being developed in the process with Globus for accessing it. And we now have a panel where we're talking about how can we implement results from this to advance health equity in our health systems. I think you spent some time at Rush before moving to Wisconsin, is that right?
Yes, that is true.
So your thoughts about this, how do we apply it in our health systems to, I think, move towards the gold star of health equity from this work?
Yes, it's more complicated now with our political environment than I think it ever was before. And a lot of it might involve making the case for the longer term interventions that we are starting to see evidence of improving. And I know I heard people discussing like the ability to support and people to move from different locations, and which is just so difficult given lots of parts of getting a house and having equity in that as well. So I do feel like this is one of these where we might have to start is just understanding the implications for what we're saying, and sometimes removing the impetus on the individual who's in that situation or in that neighborhood from fault while trying to allow more flexibility. And sometimes it's just realizing that if it's not their choice to be there, it's not something that they're going to be able just to address quickly. So it's almost just a change of our own thinking when we're addressing these points. Though I've been guilty of it myself, like when we're thinking about, oh, could the family just go to a school district that would be more supportive? And it's like, well, that's not actually that possible for them. I'm sorry, I'll let anyone else who had a thought on that, I'm sure.
No, that's an incredibly important point. Thank you for bringing that up. Someone with a young child and who had interstitial lung disease, I was in a NICU. I know, as long as knowing the parents aren't, like, wasn't our fault, it helps a lot. But then what can you do when you get to trying to, I guess, have social interventions to help and thinking that through?
there was some really nice work that was done where people were almost more support in navigating the healthcare system, and which even having like an individual social worker that was helping people sort of follow up avenues. So that would be something that we've seen that in some research projects where someone is able, or at our own, where you would make a referral to a different team, where there'd be someone to actually walk the family down the hall into the next unit, where that sort of little things like that has been helpful in maintaining family contact throughout multiple points of care. I'm not sure if that's been discussed already.
I think the other point too, Charmaine raised is that, I guess, and Sam as well, that, and Tony, that if we can establish causality with some of these determinants, then that could be built into anticipatory guidance in ways that's really powerful. It's at the local level because it's geocoded right out of the neighborhood, and that taking the judgment away piece, but still finding like, this matters, the exercise matters, or the exposure to smog matters, or this kind of thing in your own neighborhoods. So we're just learning this. We've just discovered this, by the way. Can be really powerful, for a clinician to a patient and to parents. So, other thoughts, Tony? You've been doing this work at Endeavor for a while, data analytics and a whole range of things. What are your thoughts about health system integration, migration? Because these are big, complex data sets, and there's all kinds of data security issues. And
yeah, but it's one of the genius of the Sociome is the way it has structured the social determinant data in such a way and made it computable in such a way that, first of all, there's no patient data there, so it is not something that could be used to leak or disclose inappropriately any PHI. At the same time, it's available to be linked to patient data for any particular study that you want to do. I think that's a kind of ingenious architecture that's been adopted. And it's obviously, because it's been structured in that way, it can grow. As we discover new data sets, we can add them to it. It presents a fairly uniform API, as we describe in the application programming interface, that enables you, not to have to learn how to link in every time. You can, once you've learned how to interface to the Sociome data commons, you'll be able to use it over and over. So in terms of, all the activities that we'd like to do, it presents a really friendly environment.
Yeah, so we talked about LEAF, and Endeavor is joining LEAF as well. So are you saying this kind of OMOP model might allow data mart to bootstrap on Sociome variables to diagnoses, cohort discovery?
Interestingly, the LEAF is agnostic about the common data model underlying it, and in fact, in the ITM, we've chosen to model it on the PicoNet common data model rather than OMOP. And it's attracted a lot of attention, even from outside the CTSA. But I mean, Sam did a great job of explaining how the cohort discovery, the Sociome data commons, and something that we haven't really got very far with yet, but the collaborator finder would work together to make an ecosystem that will be very supportive of research.
So thinking about how then to implement results from this in our communities, Sam and others, are there discussions with CDPH, with community-based the CBRN about how to, I guess, expand this work towards community engagement.
Yeah, I'll just say at a high level, I'll let the others answer because they're more versed in this, but we had early work with CDPH before leadership changed, and we had a lot of involvement from the prior CDPH director in the initial development of our concept. I don't think we're quite at the same level of engagement with CDPH as we were before, but we'd like to certainly get back to that level, both with CDPH and IDPH. But I'm not sure if Sharmili, Emily, or Tony have other things they want to say about our engagement with the Chicago Department of Public Health.
Well, interestingly, we've always said that the ITM is open to collaborations, and we have a huge overlap in membership with the Capricorn Common Data Network. The CDPH has been lately collaborating with Capricorn quite closely. And I mean, personally, I see no reason why we can't extend that, why we can't deepen that relationship. I have to say, and this is something we have discussed, that the community aspect of the Sociome Data Commons can be a double-edged sword. It can, blight a community as well as support it by painting a bad picture of the situation. This is something that members of the ITM have brought up before now, and therefore we're very, very careful in how we're going to go about making access to the Sociome Data Commons open. On an idealistic level, one could say, why don't we throw it open to everyone in the community if they want to write a grant application, if they want to make a case to a store that it's worth opening a store in their area? Wouldn't that be a great benefit? But then you could also have what we've described as machine learning redlining, because of who has access to that data.
I see. So this might drive property values down, or this might,
for example,
pejorative interpretations that could be hurtful if not done delicately.
I was just gonna add, I do work with some community organizations, and I think related to environmental health equity, and I think one of the things that the community is often looking for is that data, because they know, living in the community, they know that their air quality is bad. They know, that they have noise pollution or other aspects. They know that they have less tree cover, less parks, but being able again to show this at a hyper local level. And so I think it is important to be able to share these findings with the community, but also then the community could definitely use this in use that data to help fight for policy changes. So I think that is like an important point, that again, utilizing this hyperlocal data in certain communities, so then they can share that, because I think that is as powerful as the community voices itself or community stories.
And Shirley, it's so nice when, Shirley, I feel like you're doing it in the perfect way, where you have the connections and then it can empower the community, and where you have to, if we didn't have such a good relationship with the community, if you're just coming in and listing bad things about, I think that is where it could do the harm that Tony was talking about. But when you do have, it can be beautiful when you can provide the evidence for what they were looking at and maybe didn't have the ability to obtain for themselves without this data point, to then really push to make an argument for care and services that we know would be helpful to mitigate some of the adverse effects. If they can't move, but we know we can increase tree cover, then that can be an advocacy point for like a long-term change in a community.
Yeah, these are great points, and it really segues to the next question, which is policy change to promote equitable care and outcomes. And this idea, and Dr. Sally Jensen raised a question about this, but how can this be leveraged to improve health policy towards health equity? Are there examples of, I guess, empowerment, media advocacy that has resulted from these kinds of data? I mean, historically there have been, but can you talk about this issue of how people could be armed to go to their senator or their local congressperson and say, look, we really need legislation to clean up this neighborhood, or to, invest in green spaces and community gardens and walkable sidewalks, things like that. It seems, we've seen inspirational movies about people who stand up and they fight against big corporations to prove that they cause cancer, and then they hopefully will have major reform. But it must be intimidating for people to do that. So thoughts about how this might be used to activate change?
The picture that Sam used in his presentation, I think you credited San Francisco for it, that shows the upstream and the downstream effects, the upstream causes and the downstream effects. The interesting thing is that comes from a policy document. So people have been thinking in these terms with a view to policy. I mean, what one might hope to do with this work is provide, more granular and detailed evidence to support policy changes.
Yeah.
Obviously, the big question is, how does all this play out now with, did we even take a risk of mentioning the word structural racism in my talk today? Like, I think this is a whole new world we're living in now. And I, for one, am going to keep standing up and saying what I think is the right science. But I think every day we're being peppered with more and more pressure to not do that. So I think when it comes to policy change, it's a much different ballgame than it was a month ago.
Yeah. Somebody copied me a couple of days ago the 7 pages no less, of terms that that Senator Ted Cruz finds offensive in NSF funded proposals. Not NIH on this occasion, but NSF.
And obviously, we could have a whole therapy session here about change, but I think, I think as we think about policy change, we're going to have to be more creative and selective about what we're promoting and where we can have the highest level of impact.
Yeah. I think in terms of other agencies besides HHS to think about too, do we have a way to really communicate to policymakers at HUD or FEMA or other agencies things that a lot of this involves environmental work, change, and are we looking to the right agencies for ways to make these big structural changes? Can we do better? And the pendulum will always swing back and forth, and hopefully we'll get through this one. But I just think that people are listening more to this kind of work. I think the more you can show granular data, it could be very activating. Getting policymakers to listen is a challenging one. Someone mentioned EPA, for example. If they don't shut it down with DOGE, then what can EPA do? All right. Well, I think just moving on to translational science. So this is an example of translational science in that it really is developing a whole range of methodologies and a new paradigms about how to think about data collection and how to access it. Thoughts, Sam, about going into the next CTSA cycle and so forth? This is a big issue. Where do you think you're going to go next with Sociome Data Commons, and where's it going to go 5 years from now?
I mean, I'm just thinking about the work I'm doing in my own lab right now. I think the next 5 years are really going to be about patient control data and patients controlling access to their own information. I think there's the folks on this call are much more well versed in this than I am, but the kinds of data you can get directly from patients includes things like direct access to their EHR through leveraging API access into Epic and Cerner, but patient-reported outcomes, wearables data, information about their shopping habits, and information about their travel. And if these are done in a way that is sensitive and respectful of their privacy, but also done in a way that allows you to connect these threads together, I think it could really lead to our vast improvements in our ability to develop translational science for patients. But maybe that's too pie in the sky, but that's my thought about the coming 5 to 10 years or 5 years.
I can imagine a personalized map of toxins or hazards or things, just so people are aware of it, but doing it in a way that's not going to scare the living daylights out of parents. And
well, it's all about relative risk. You have people that aren't afraid to smoke cigarettes, but then they worry about the amount of radiation in a CAT scan. So I think helping people understand relative risk, and I'm sure many people have read the book Innumeracy. I mean, there's a lot of ways that we talk to people that can be improved if we have the right kind of evidence.
Thank you. And Tony, yeah.
Oh, I was just going to add another way that we're thinking about utilizing this data more in translational science is with epigenetics. So trying to think about what are some of these sociome factors and how does that maybe characterize like gene regulatory mechanisms, whether it be DNA methylation or gene expression. So those are other ways to kind of think about using this data. I think in the past, a lot of it has been on individual behaviors, like again, smoking or physical activity levels, but also thinking about, again, more broadly, what are some of these neighborhood factors that may be impacting gene regulation?
Yeah, and things like infectious disease as well, where enterovirus can cause methylation of cells and maybe lead to type 1 diabetes, things like that. How do you then tie it all together? The intersectionality of causality in these data is really fascinating from a translational science standpoint. Emily, you're nodding.
Yeah, I was thinking too across development. That's where my research is, like in lifespan development, and it would be really interesting to sort of say what Sam was saying, like those risk or like the map of risk that you were talking about, Sean, with him, where we were accumulating over time, or maybe certain points in our life where we're more vulnerable and we can think about exposures at certain points. So that's like not what we have right now, but I think it could be something that we are working towards down the road to see how these factors impact, but maybe have a bigger punch at certain points.
Mm-hmm. I mean, this is just my impressions, but looking at some of these geocoded maps, it's really intriguing to think about how is it all going to fill in, like an old-fashioned Etch-a-Sketch. As more and more things come in, are there going to be some new causative moments that, not causative moments, but is it going to crystallize new hypotheses about relationships as we put it all together? I don't know how to do that, but it sounds like it's a dynamic process of just learning how to analyze the data too. Other thoughts, Tony, about translational science and where this is all going?
I find the Sam's suggestion interesting that though perhaps a sad conclusion from turning away from the political, because it is so difficult looking at what we can do for the individual patient, including, all the good stuff that he talked about, such as, better access to records and better understanding of their condition, the aspirational learning patient in the learning health system. And perhaps that might eventually lead to changes at the political level.
Well, thank you. Well, this has been a really enlightening seminar, and I feel like I'm way out of my depth. I'm not a informaticist, but I'm really grateful to see this work, and I do hope that it does over time lead to empowerment of patients and communities and improved policies. But I think this data, as it becomes increasingly powerful, will have its own, hopefully be empowering to health equity efforts. So I'd like to thank the panel, and also thank Rachel for helping to facilitate this seminar. Rachel, did you want to talk about the evaluations?
Oh, sure. Yes. Actually, I will be sending out an evaluation at the end of this meeting. I will send it in an email. So be on the lookout for that email. I'll include the link to today's presentation that was provided in the chat. So yes, that will be coming.
Excellent. And then we'll be posting a video of this on our YouTube channel as well.
Correct. It will be posted on our video channel, on our YouTube channel by Friday.
Excellent. Okay. Well,
Yeah, thank
thank
you
you.
for the opportunity. We look forward to collaborators, and we want to work with people. And it's great to work with Tony, Sharmali, and Emily, and looking forward to building this out.
Thank you so much. I know you're all incredibly busy, but it's been a treat to really see this work develop over a short time, and it is very noble, important work. Thank you so much.
Great. Thanks all.
Okay. All right. Rachel, I don't want to end it before it's been recorded and captured, right? Do we have this? We're all good? Okay. Thank you.